So welcome everyone. This webinar is jointly organized by SRHM Journal and PMNCH, the Partnership for Maternal, Newborn and Child Health. It marks the launching of the theme issue of the journal on universal health coverage, sexual and reproductive rights in focus. Some papers for the theme issue are already up on the journal's website, and more papers will be coming up throughout the year. This has turned into a very popular issue, and a large number of papers have been submitted and are at different stages of the pipeline. So this will be a large special issue, quite appropriately, given its subject matter and given the times we're living in. Today, our webinar is going to take what is the subject matter for the theme issue and extend it to look at the implications as a result of the pandemic. COVID-19, as we know, has done a number of things, but among them, our question for today is whether it has exacerbated some of the fault lines that already existed between universal health coverage and sexual and reproductive health and rights. The tensions and the fault lines of SRHR in the context of UHC includes a range of things, as we already know. These have to do with the content of service packages, whether service packages under universal health coverage include key SRHR elements, whether financing is adequate to ensure that SRHR is covered and that the people who most need SRH services are covered. And very importantly, the question of rights, whether sexual and reproductive rights, including safe abortions, access to contraception, sexuality, comprehensive sexuality education, violence against women, disrespect and abuse against women during maternal care, and a number of other issues which highlight the problems of reproductive and sexual rights are covered in the context of UHC. We also know that these fault lines also cut across groups of people. Women, of course, adolescents, people with disabilities, LGBTIQ people, and those belonging to specific indigenous, ethnic, racial, caste, or other groups. The fault lines cut across these groups as well. And part of our discussions today are certainly going to be looking at whether these groups are being further marginalized in the context of COVID-19. We also have the major issue of women health workers who, as we know, are at the bottom of the hierarchy of health workers, and unpaid care, health care that is typically provided by women. This webinar, therefore, hopes to begin to extend the analysis that we already have and that is being highlighted, showcased in the special issue to look at what the pandemic means. I now want to introduce our speakers, the panelists. So I'm going to request our panelists to turn on your video, please. And yes, there we go. So I'm going to just briefly introduce our panelists in the order in which they're going to be coming in. Right after me, Helga Fogstad, who is the executive director for, and you can raise your hand to show people who you are in case they can't see, who's the executive director of PMNCH, will make introductory remarks on behalf of PMNCH. And then we will move on to the Right Honorable Helen Clark. Helen, it really needs no introduction. So I'm literally going to say one line. Former Prime Minister of New Zealand, former UNDP administrator, currently the chair of the board of PMNCH, and always a passionate and articulate spokesperson for gender equality and the human rights of all. Our next speaker will be Sundari Ravindran. Sundari is Principal Visiting Fellow at the UN University's International Institute for Global Health. Sundari is based in Trivandrum in Kerala in India. And let me back up for a minute. Helga, I'm not too sure where you are right now. Oslo?
No, I'm in Geneva.
Ah, in Geneva. Helga is in Geneva and Helen is in, you're muted, Helen. New Zealand, but where?
Helen is in Auckland, New Zealand at 12:15 at night.
Ah, thank you for agreeing to be with us at this time. After Sundari, we have Alan Malechy. Alan's the Executive Director of the Kenya Legal and Ethical Issues Network on HIV and AIDS, KELIN, and is based in Nairobi, Kenya. Alan, where are you? You're there somewhere.
Nairobi, right in the middle of it.
Okay, great. Thank you. The speaker following Alan will be Naomi Lins de Roche, who's based in Johannesburg, South Africa, and is a senior research scientist with the Guttmacher Institute. And finally, last but definitely not least, is Manjula Narasimhan, who is in the Department of Sexual and Reproductive Health and Research at the WHO in Geneva. As you can see from the list of panelists, the range of topics that they will be covering is a wide and very interesting one. And we hope to hear both about the challenges and possible opportunities that there may be to advance sexual and reproductive health and rights during what is undoubtedly a very difficult time for health systems and for the agenda of universal health coverage overall. So let me give you a few instructions that you probably already know. Please mute your audio and video. You're welcome to tweet during the session. You're also welcome to use the chat. Please use the chat for everyone, not the chat for the panelists. Please use the everyone chat. If you have questions, please put your questions up on the everyone chat, and they will be monitored, and we'll be selecting a few questions for the panelists to address at the end. Each speaker will be speaking for about 6 to 7 minutes, and the questions for all speakers will come at the end. So without ado, let me pass it on to Helga to speak on behalf of PMNCH. Over to you, Helga.
Thank you so much, Gita, and thank you for moderating us today. On behalf of the Partnership for Maternal, Newborn and Child Health, as well as Sexual Reproductive Health Matters, I want to give a warm welcome to all of you for joining us today. I'm delighted to be beamed in your home offices, be it on your sofas, on your at your kitchen table, from all around the world. I understand we are now over 900 participants. So this is great. I just want to share that over a year ago, at the beginning of the year 2019, it wasn't only us that were worried. We, together with partners, were worried in being able to successfully get sexual reproductive health issues on several of the key global health agendas. And so sexual reproductive health matters, and ourselves began discussing this and reaching out to partners in order to see how we can better mobilize ourselves in a systematic way so that we all are able to get key issues, generate diverse evidence on the needs and rights of marginalized populations, on accountability, on how rights matters, such as consent, choice, and non-discrimination. These are all integrated into the UHC agenda. So this theme issue is especially timely in light of the political declaration of UHC that was agreed by all countries at last September's high-level meeting at UNGA. Countries have stated their commitments, but we need additional evidence and momentum to support all countries in reaching them. And today, we know that this conversation is more urgent than ever. The COVID-19 pandemic has put enormous strains on health systems worldwide. It has reignited conversations in policy and public spheres about the basic rights to health and the responsibilities of governments to make good quality health services available for all. The crisis has also exposed how, in a flash, the lives of millions of women and girls can be put into jeopardy when resources for SRHR services are diverted, stopped, or deliberately attacked. So I'm truly delighted to launch this special issue today. You can find a first selection of papers live on the SRHM website, and additional papers for this collection will be published on a rolling basis in the lead up to the Human Rights Day on December 10th and the UHC Day on December 12th. The country case studies elaborate in collaboration with WHO will also be available and will be included in the connections with the Virtual Health Systems Research Conference in November. So we have very distinguished panel. Without further ado, let me once again say a big welcome and hand it back to Gita to moderate our panel. Thank you. Over to you, Gita.
Thanks very much, Helga. Let me now invite Helen Clark, who's going to be speaking to us on upholding rights and investing in health, an opportunity to build back better after COVID-19. Over to you, Helen.
Thank you, Gita. And thanks also, Helga, for your opening remarks, and to our partners, the Journal, which is publishing on this very timely topic of achieving universal health coverage and sexual and reproductive health and rights during and beyond the pandemic. When the idea of producing a special issue with the Journal first emerged, of course, we were working in a very different context a year ago, focusing on the preparations for the UN General Assembly's high-level meeting on universal health coverage, and the usual battles were raging in the corridors of the UN over sexual and reproductive health and rights. A lot was at stake. Well, a lot is still at stake. In these unprecedented times of the pandemic, which began as a health crisis, has become a full-blown global economic and social crisis, we find ourselves in the sadly rather familiar territory of having to fight just to preserve gains made for sexual and reproductive health and rights while we're still trying to move that agenda forward. We've seen the pandemic directly claim rather more than 400,000 lives now, but that's just the tip of the iceberg of the damage it's doing. The death toll is far higher if we include the indirect deaths which are coming from restricted access to services and these harsh socioeconomic consequences. And beyond the impact on mortality rates, we also see the pandemic impacting adversely on other global targets which are so central to women's health and empowerment and progress. So this pandemic is still spreading around the world from epicenter to new epicenter, but it's not too early to begin to consider what lessons might be drawn from our degree of preparedness for it and the response that's been made to it. And this has been the focus of the article by Anna Grunding and me in the Sexual and Reproductive Health Matters theme issue. So in brief, what are the lessons that we see? Well, lesson one, achieving health security and achieving universal health coverage are mutually dependent. Countries just have to invest in both or risk further devastating loss of life and economic and other setbacks from future pandemics. Without proper surveillance and preparedness, such outbreaks of disease place an enormous burden on communities and health services. And when people can't access health services through universal health coverage, they can't get tested and treated. And systems of quarantine and self-isolation cannot be effective. All of that contributes to the spread of infectious disease. We see COVID-19 thriving where inequality continues to fester. So the return on investing in universal health coverage is having a healthier population with all the positives that that brings for individuals, for families, for societies, and also having more resilience in the face of global health threats. Our second lesson, it's vital that a comprehensive package of sexual and reproductive health services is fully integrated into every national universal health coverage plan, and it must be fully resourced. Because of deep-seated gender inequality, including in access to decision-making, sexual and reproductive health services are more vulnerable than other health services to cutbacks in times of crisis. During this current pandemic, we have seen some leap at this new opportunity to roll back women's access to these essential services. So ways have to be found to embed, to entrench sexual and reproductive health and rights in health plans, laws, and policies. And these services and rights need to be actively defended, especially in times of crisis. We think it's also possible to expand services in innovative ways, including through telehealth, and to put more control in the hands of women themselves. Access to self-injected contraception and to medical abortions can be strengthened. The World Health Organization has recently published new guidance on self-care interventions in sexual and reproductive health, and we look forward to hearing more from Manju on the panel later on this. Our third lesson, in normal times and in times of crisis, whenever, wherever, a human rights-based approach is both the right approach and a highly effective approach. We need that approach now to both universal health coverage and to sexual and reproductive health and rights. We know from experience of addressing other epidemics, such as HIV/AIDS and Ebola, that where there is discrimination, that is detrimental to the health of individuals and communities discriminated against, and that it hinders the overall public health response. We've seen discrimination also rear its ugly head during this pandemic, against migrants, against refugees, against LGBTQI populations, to name just a few. So human rights, including an emphasis on non-discrimination, has to be the cornerstone of current and future public health responses to pandemics. And our fourth and last lesson, Leadership matters. Lack of leadership hurts in pandemics. Leaders who have just failed utterly to address COVID-19 seriously, have let their countries down. The UN Security Council has failed to respond to the clear threat which the pandemic poses to global peace and security. The G20 has yet to lead on mobilizing an effective response in the way it did to the global financial crisis. More than 100 countries have now applied to the International Monetary Fund for emergency support. Currently, it does not have the resources to meet the need that's being expressed. But we've also seen inspiring examples of leadership during the pandemic, including from many of the world's female heads of state and government. Examples where everything that can be done is being done to protect the health of their populations. As well, the European Union and partners led a very successful €8 billion fundraising initiative to support the WHO-launched Access to COVID-19 Tools Accelerator. And that's a global collaboration which is funding diagnostics, therapeutics, and vaccines for all. Earlier this month, we also saw governments pledge $8.8 billion for Gavi, the Vaccine Alliance, to help immunize 300 million more children in the world's poorest countries. Governments and philanthropy and others came together for that. So perhaps above all, the lesson we must draw from COVID-19 is that one of the most effective public health tools is good leadership. Good governance matters, accountability matters, and part of our work to build back better for next time must be to support and equip the next generation of leaders to handle the next pandemic well. There surely will be a next pandemic, and let us hope that the response to it is not as flat-footed in so many places as we have seen during this pandemic, despite, in my humble opinion, the very best efforts of the WHO to rally countries to fight it. Thanks. Gita's on mute.
Sorry about that. Thank you, Helen, for that rousing call against flat-footedness. And I completely share your views, as I'm sure many will in this group. Our next speaker is Sundari Ravindran, and she's going to be speaking to us on the basis of a review of recent evidence on SRHR in UHC packages. Over to you, Sundari.
Because my bandwidth doesn't support it. And without much ado, let me start my presentation. Sorry. Yeah, it's from a paper co-authored with Veloshni Ganga, which has reviewed recent evidence on where we stand vis-a-vis universal coverage of SRH services in low and middle income countries. I don't need to explain to this audience the need to prioritize sexual and reproductive health services in national UHC plans and processes. The two are mutually interlinked, and we know that if there is unmet need for reproductive and sexual health care, you cannot have UHC. And yet, Sexual and reproductive health actors are rarely at the tables where UHC decisions are made. A little bit about our methodology. The review included 253 documents, mostly published between 2010 and 19, and of UHC. The evidence base is weak and fragmented, and we have stitched a story together from what was available. So what are some key findings? The first is that the essential health services packages, which Helen referred to as should be only a few specific SRH services, as you may guess, maternal health, family planning, HIV/AIDS for the most part. Even in countries that have included other services, such as gender-based violence or reproductive cancers, the services may be only on awareness on gender-based violence or screening for cervical cancer. Most important, although inclusion in essential health service package is in reality because governments have not allocated the necessary finances. So services are not available in the public sector and often unaffordable in the private sector. Also, SRH actors from civil society as well as other sections seem to play a limited role in what goes into essential service packages. The second key finding is about financing. Who pays for sexual and reproductive health services? The lion's share in low and middle income countries is out-of-pocket expenditure by households. To some extent, a little bit by governments and less so by all other sources. This means catastrophic health expenditure. International funding, as you will see, is rather limited. It is dominated by the United States and therefore predictably volatile. Most of the funding has been for HIV, with MCH and family planning holding distant second and third places. And this has been a consistent trend since 1995. There are some emerging blended modes of financing, such as the global financing facility, but SRH actors have raised several concerns about this mode. I will not go into this at this point. But then, to some unique challenges to the delivery of SRH services. Perhaps SRH services is the only area in health where life-saving services are denied by legal and policy barriers, and routine violation of human rights happens and without recourse from law. Restrictive gender norms and gender inequalities in households and communities and gender biases within the healthcare system affect demand for services. And on the other hand, gender blind policies and programs limit access to care. There has been a major trend towards engaging the private sector in sexual and reproductive health service delivery, such that there are limited benefits to doing so. And in contexts where private sector regulation is weak and the for-profit sector is powerful, it is antithetical to UHC goals. We know what needs to be done, but let me say it once again. Prioritize a comprehensive range of SRH services, ensure increased and international for the full range of SRH services. Most importantly, removing legal barriers and policy barriers and ensuring gender responsive programs is also a UHC task. And last but not least, evidence. we have very weak evidence, and we need to put money where our mouth is, involving practitioners from the countries that are experimenting and taking different paths. And everything, all the challenges that I have said so far comes forth in an exacerbated form at this time of COVID-19, such as safe abortion, and the most marginalized populations, cultural and logistical barriers are the most affected. To give just an example, according to a study by IPAS Development Foundation in India, 59% of women from 12 states were denied abortion during the initial 2 months of the lockdown. But this is also an opportunity to make some radical changes to enable access. For example, some countries and even WHO's recent guidelines countries have talked about self-management of medical abortion. Is also easing of prescription and make these also survive beyond. Thank you.
Thanks very much, Sundari, for a really thoughtful set of comments based on your review and for that positive ending. Our next speaker is Alan Malechy from Kelin, and he's going to be speaking to us about the missing link in Kenya's UHC experiment, a preventive and promotive approach to SRHR. Alan?
Thank you for having me. I will use slides, and the context of my presentation or conversation would be around what went right or what went wrong with our UHC coverage program, which we choose to call an experiment, and how it failed to take into account aspects of preventive and promotive aspects of sexual reproductive health rights. I will also speak briefly and intertwine my presentation with what COVID has done in terms of disrupting the daily flow of services to women, girls, and adolescents who require sexual reproductive healthcare services. And this is based from our paper that we have submitted to the journal alongside with my colleagues, Lisa, Annette, Nerima, who have greatly contributed to this. Next slide. So I'll quickly cover 4 areas around the legal framework in Kenya to help our audience understand what we're battling with, the positive aspects of our UHC experiment in Kenya, the challenges we have faced, and what in our view we see as the next step for UHC and SRHR. And as I said, all this will be done in the context of COVID and how that has affected the uptake of services. Thank you. Next slide. So as a lawyer, I know we are not short of legal frameworks in Kenya. We have robust legal policies, laws, guidelines on issues of human rights, on issues of the right to health, on issues of on issues of sexual reproductive health. And we are also a signatory as a country to many international instruments that guarantee access to SRHR. We also have a number of judicial decisions that address issues of SRHR and the right to health. But as a lawyer, I have come to discover that it's not only about having the legal and policy framework, it's whether it's actually being respected, it's actually being followed, and actually whether the person on the ground, be it the man, the woman, the adolescent, the person with disabilities, actually accessing these services. And what COVID has taught us is that there has been a disregard of rule of law, and particularly on matters SRHR, we have seen the challenge where rules, regulations are not being respected, and they have had consequent negative feedback towards the uptake of SRHR services. But I will come to revisit this, but the point here is that even where you have a legal and policy framework in place, what's your role in trying to ensure that it actually serves the needs of those who require comprehensive sexual reproductive health services? Next slide. Now, our UHC program and project had certain positive aspects, just like COVID has had. There was a big political will, with UHC being part of the president's Big Four agenda. The other aspects were around housing and socioeconomic rights and access to food. And as you can see from a number of posts, the president really supported this agenda. Same way he has come out strongly to try and ensure that we have a robust COVID response. And within that framework, there was a program called Linda Mama. Linda means take care, that was supposed to be specifically focusing on aspects relating to SRHR within the context of conversing on universal healthcare coverage. And I've had colleagues earlier on speaking about comprehensive packages. We were lucky to have a task force, a local task force that was formed to design an inclusive universal healthcare coverage package for the country, which tried to go around to get people's views to be able to appreciate what would be an ideal package for UHC. But moving forward to the next slide, you'll be able to see that there were challenges we have faced, and these challenges are not unique to Kenya, and you also happen in other areas. I'll point out 4 of them which affect access to SRHR services, but also are being seen in the times of COVID. The first one is the fact that we have not invested well in healthcare workers in terms of their working conditions, in terms of their workplaces, in terms of their safety and occupational hazards around them. And this has seen a lot of challenges. So our UHC process and the pilots that happened in 4 counties, Nyeri, Kisumu, Isiolo, have seen, especially in Kisumu, a lot of strikes, a lot of labor problems with healthcare workers, and this has affected them access to services. We've also seen in the context of COVID, at the start of it in Kenya, many healthcare workers afraid of providing services because of the lack of protective personal equipment available to them, and this has also affected access to services. Again, the second big challenge has been right to information. And this has been seen both in COVID and the UHC context, where it was not clear who pays for what service. In the context of Kenya, health is devolved. You have a national government that is in charge of policy and looking at the national health facilities, and you have a county governments, 47 of them, that are charged with service delivery. Now, there's a lot of confusion, and because of the lack of information, the lack of respect of rule of law, many things fell through the crack. And one of them was that in the UHC program, many women ended up being detained in hospitals for lack of paying maternity fees after delivery. And again, this has come to play in the COVID situation, where the role of the national government and the county government has not come out clearly and largely mirrored around the issue of right to information. Next slide. So moving on, I think the challenges we have seen and that we need to take into account when we are looking at issues of UHC, SRHR, and also in the context of COVID, one is that we need to look at the financial architecture of financing. And especially in the context of Kenya, where health is devolved and you've got different insurance schemes, how do we align that architecture to ensure that it feeds into the need of the people? Because that confusion has brought problems. We need to ensure that reduced corruption, leakage, and wastage of resources is addressed, because we have already seen reports coming up that there's not good accountability and use of PEP in the country, that there are people who are actually making wrong use of it and not being accountable to it. And we also saw cases of lack of transparency in the process of UHC. To date, the Memorandum of Understandings between the national and county governments relating to UHC have never been made public. You'll see an image there where Kelly, working with other institutions, wrote a formal request for information in 2018 to ask for these documents, and this has never been honored. And this is the same thing we see in the context of COVID in Kenya, where there are a number of organizations and people writing letters to say, could we know how many PEPs are there? Could we know how much funding the government has gotten? And that has never been responded to or made available. So the importance of access to information is that it helps promote transparency, it helps promote accountability, it helps community and civil society play the role of ensuring things don't go to waste. Lastly, and most importantly for UHC and for SRHR, our UHC projects have really turned a blind eye on the preventive and promotive aspect of UHC and SRHR, and we've largely focused on the curative one. So going forward, we need to be able to take into account this particular aspect of how do we ensure that our goal is to ensure that people are not getting sick and not focusing on only treating them. And I must say that in the context of COVID, the directives of people staying at home, the curfews that have been enforced, have actually seen some rollback in the gains that we have made with women delivering in hospital. And it has taken a lot of advocacy for the Ministry of Health to develop guidelines and to see that police brutality is reduced. So I'll end the conversation there, but happy to share more information during the question and answer session. Thank you for listening.
Thank you, Alan. I see a bunch of questions showing up on the chat about budgets, and that's very timely because our next speaker, Naomi Linz-DeRoche from the Guttmacher Institute, is going to be speaking about a comprehensive human rights approach for SRHR budgeting in a time of limited resources. Naomi?
Thank you. Thanks for the opportunity to participate today. Before I begin, I want to acknowledge my co-authors at the Guttmacher Institute who are listed here on the slide. The work that I'm presenting today draws from a larger study called Adding It Up. Adding It Up assesses the need, impact, and costs of offering more than 90 sexual and reproductive health services. The most recent iteration of Adding It Up, which covers 2019, includes all 1.6 billion women of reproductive age in all 132 low and middle income countries. That report will be released in July this year. For the work I'm presenting today, our aim was to use the Adding It Up cost data to show how comprehensive investments can not only ensure that rights are met, but also potentially result in cost savings as we move toward universal health coverage. And why focus on costs? No amount of increased revenue for universal health coverage will ensure equitable and efficient service delivery if systems for financial management are not aligned with programmatic objectives. Simply stated, countries can declare that they're working towards universal access to sexual and reproductive health, but unless their financial management systems allow for planning and monitoring of progress in that regard, they risk falling short of their goals. To underscore the interrelated nature and synergistic impact of investing in sexual and reproductive health, we chose 3 service bundles: abortion-related care, STI management, and safe childbirth services. Each of these bundles includes a preventive service and other services that are impacted when access to the preventive service is scaled up. For each of these 3 service bundles, we explore costs in 3 scenarios. 1, current coverage levels for preventive and impacted services. 2, when we meet all need for the impacted services, but keep provision of the preventive service constant at current levels. And 3, when we meet all need for both the preventive and impacted services. And as noted in the box here, we also include in our results country and region-specific costs for all of the interventions in the larger Adding It Up analysis. I'm not going to go into those results today, but they can be found in our paper, which also contains all of the detail on how we estimated the intervention costs and our methods for estimating the numbers of women in need of the types of care included in these service bundles. So our results. I begin with abortion-related care. In the leftmost column, you can see that we estimate that the current direct cost to health systems for providing safe and unsafe abortions across all low and middle income countries is $526 million annually. That's the combination of the 2 green parts of that column. The additional cost of providing post-abortion care to manage complications from unsafe abortion is $869 million. And in total, we estimate an annual current cost of nearly $1.4 billion for abortion-related care. But we know that many women who need post-abortion care don't receive that care. If health systems in low and middle income countries were to scale up their post-abortion care to meet all need, as in the middle column here on the slide, the cost of offering post-abortion care in blue there would rise to nearly $1.5 billion. In scenario 3, or the right column, we explore what would happen if all women who needed an abortion were able to get that abortion safely through the health system. Of course, costs for providing safe abortion services would rise. We estimate a rise to $643 million annually, in green there. But the need for and costs of providing post-abortion care would fall dramatically to $119 million. Comparing the current situation, or scenario 1 on the left, to this hypothetical scenario 3 on the right, shows that low and middle income countries could reduce abortion-related spending by $633 million annually if they were able to expand access to these vital services in a way that recognizes women's right to reproductive autonomy. That's a 45% reduction from current costs. And these costs don't include the indirect or programs and systems costs that underpin our ability to provide this care. The savings would be even greater if we included those costs. And here we have STI management. I'm simplifying this example, showing just the first and third scenarios, or current care and when all need is met for all services. In the left column, you can see that current spending for treatment of chlamydia and gonorrhea in the pink colors, and pelvic inflammatory disease, or PID, in purple, totals an estimated $188 million annually. The PID costs comprise the majority of those total direct costs, largely because of the significant numbers of untreated cases of chlamydia and gonorrhea, which lead to PID. Then in the right column, where all need for treatment of chlamydia and gonorrhea is met, the pink portions of the bar expand upward substantially. That reflects the true need for treatment of these. The direct cost for meeting that need would be $466 million annually. But you can see that when we treat all chlamydia and gonorrhea, the costs of treating pelvic inflammatory disease fall away completely, freeing up what we currently spend there. And now the third service bundle. These columns on the right of the slide show spending on birth-related complications, many of which can be prevented through provision of high-quality delivery-related care and health facilities. The costs are very similar in these two scenarios, current care on the left and the all needs met on the right. But the impact on women's lives is not. On the left, many women and newborns are not receiving safe childbirth services, and we're falling short of meeting need for treatment of complications. On the right, all women and newborns receive safe childbirth services, reducing the need for expensive curative treatment to such an extent that health systems are able to meet that need within the current budget envelope. Finally, the COVID-19 pandemic. It's impacting health systems in largely unmeasured ways, but there is emerging evidence of reductions in access to sexual and reproductive health services. Recent estimates from Guttmacher showed that even a 10% decrease in coverage from current levels of contraceptive provision in low and middle income countries could result in millions of additional unintended pregnancies and unsafe abortions. The stakes are high. We must work to advocate for continued funding of sexual and reproductive health care. Fortunately, the pandemic is also exposing bottlenecks and weak points in the ways that we provide access to services and forcing us to work in new and creative ways. For example, the pandemic is highlighting shortages of healthcare workers and upsetting supply chains. We need to explore ways to ensure sufficient numbers of healthcare workers and the systems for supporting them. We also need to do more in terms of how we coordinate access to reproductive supplies, using systems that allow for better coordination and more efficient logistics. The pandemic is also forcing us to think about service quality. It's hard to measure, and even harder to measure the impact of changes in quality on health outcomes, but we need to strive to do that better. And finally, although some sexual and reproductive health can be accessed outside of the health system, and should be, much care still depends on health systems. Health system strengthening is vital for ensuring that we can provide rights-based, comprehensive care. If we can capitalize on these lessons and others that we're learning now, we can build better systems for ensuring care in the future and further our efforts to achieve universal health coverage. Thank you.
Thanks very much, Naomi. Really interesting, and I'm sure there'll be a bunch of questions. I know I have some for you. Really interesting, the budgeting discussion. Our final speaker is Manju Narasimhan from the WHO, who will be speaking about self-care interventions as possible game changers for transforming healthcare delivery. Over to you, Manju.
Thanks so much, Gita, and thank you all very, very much for this opportunity to present. It's Gita and the previous speakers have already laid the groundwork so well on the key elements for achieving universal health coverage for SRHR. And in this presentation, I'll briefly cover some of the really exciting opportunities that self-care interventions offer to this discourse. Just to be clear a little bit on the terminology, what we mean by self-care is the ability of individuals, of families, of communities to promote health, prevent disease, maintain health, and cope with illness and disability with or without the support of a healthcare provider. And we're all familiar with some elements of self-care, whether it's the steps we take for better nutrition, for physical activity, mitigating stress. And in the context of COVID-19, for example, self-care actions include the physical distancing, good respiratory hygiene, hand washing that most of us are practicing. What we mean by self-care interventions are the evidence-based tools for better self-care. And this could be information, medicines, diagnostics, products, or technologies. And there is a real rapid increase in self-care interventions. And it's shifting the way healthcare delivery is not only perceived, is understood, and is accessed. So for example, the correct use of male or female condoms are self-care interventions that people have been using to prevent unintended pregnancies and protect against sexually transmitted infections, including HIV. And now we've got self-injectable contraception, HIV self-tests, or the use of digital platforms to access healthcare online. And these are just among the many, many examples of the increasing number of self-care interventions, which are also relevant during this pandemic. In 2019, June 2019, actually, just a little over a year ago, WHO issued the first consolidated guideline on self-care interventions for health. And the focus of the guideline was on sexual and reproductive health and rights. And this guideline acknowledges people as active participants in their own health, both in their role as self-carers and in their role as caregivers. And the guideline also acknowledges self-care interventions as complementary to formal healthcare delivery. And self-care interventions, way that it's been formulated, is really something that should be supported by the health systems. And the links to, as well as the accountability of the health system, remains important, given that many of these newer interventions are in various stages of availability or may require varying degrees and frequency of contact with health facilities. A reflection on why some people might choose self-care interventions. And this is varied. It could be for convenience, it could be for cost, empowerment, a better fit with the values or daily lifestyles, or it could be that the interventions themselves provide the options that people want and the choice that the people want. However, where there exists contexts of unequal power and the potential for coercion or harm, people may also opt for self-care interventions to avoid the health system due to lack of quality care, or when faced with financial or other access to barriers. So for vulnerable populations who face challenges in their efforts to secure their rights and improve their health, self-care interventions could fulfill an important role, as the alternative might be that these people do not access health services at all. However, people really need to have information, autonomy, the ability to make decisions about their own lives and health. And a safe and supportive enabling environment is really important. And elements of the safe and supportive enabling environment includes trained healthcare providers, psychosocial support, education, information, access to justice, and freedom from violence, from stigma, and discrimination. We conducted a global online survey that informed the WHO guideline I just mentioned, and this provided insight from both laypersons and healthcare providers on how self-care interventions supported by the health system can contribute to increasing health coverage. And a summary of the open-ended responses we received in the global survey included the perceptions of access, of acceptability, and the knowledge of these newer self-care interventions for sexual and reproductive health and rights. And among laypersons participating, self-care interventions were described as beneficial for reducing stigma and discrimination, increasing confidentiality, decreasing barriers to access. And the healthcare providers provided a similar response. They perceived benefits also included empowerment, increased uptake, of sexual and reproductive health services, privacy, and reducing exposure to stigma. The healthcare provider respondents also noted that patients were better able to maintain their privacy and confidentiality when they're using self-care interventions. There were, however, some concerns that were raised, and these included the trustworthiness and the quality of the available products, or the potential for misuse of a product due to poor health literacy. However, despite the concerns, overall the responses to the survey, both among the laypersons and among the healthcare providers, indicated that the perceived benefits of self-care interventions far outweighed the harms. And the two key benefits that, just to summarize, would be increasing autonomy and agency, really through empowering individuals and particularly vulnerable populations. And second would be transforming a health systems approach to create a safe and supportive enabling environment that can be open and support and serve all populations, and in particular vulnerable populations. Of course, there's further research that's needed in this rapidly advancing field, and this will continue to inform the living guidance from WHO. Introducing and scaling up self-care interventions really has the potential to transform ad hoc activities into coherent policies, coherent programs that can improve sexual and reproductive health and rights and help advance universal health coverage. I really wanted to thank my co-authors of this manuscript, Carmen Logi and her team at the University of Toronto, Heather and Alice, Nandi Siegfried from the University of Cape Town, and the WHO Regional Advisors for Sexual and Reproductive Health for the Americas, Rodolfo Gomez Ponce de Leon, and the Eastern Mediterranean region, Karima Golbozuri, and for the Africa region, Leopold Ouedraogo. Thank you so much.
Thanks very much, Manjula. Let me take this opportunity also to mention that there is an upcoming SRHM, the journal's theme issue on self-care. So please look forward to that. It should be coming fairly soon. How fairly, it depends on the journal, but I think it's in the works already. So we're all looking forward to that. We've had a whole bunch of questions and a very lively discussion going on the chat while people were speaking. Let me, Helen, are you still there? Thank you for being with us in the middle of the night for you. And let me ask you the first question. One of the participants wanted to know, actually more than one, what role do you see for primary health care in building back better?
Thanks for that question. Primary health care, of course, is quite a broad concept, and it encompasses the preventive side right through the social determinants to what we might understand as direct provision of services as well. But I mean, it's clearly absolutely fundamental. And if we're looking at the role specifically of primary care in achieving UHC and achieving sexual and reproductive health and rights, we can't do it without primary care. We can't do it without that focus, firstly on population health. And I think where a lot of pandemic responses fell down was in the attrition of capacity, if you like, in population health in many countries. And secondly, I think when we're thinking of primary health care in terms of sexual and reproductive health and rights, we need to take it back to issues of environments in which there's gender inequity and inequality, where the rights of girls and women aren't respected, where there's no comprehensive sexuality education, something that doesn't normally fall within the province of the health system, but where the education system has to play a complementary role. We need to think in terms of primary health care of the importance of adequate and nutritious food. The school can be a platform for that, social protection programs can, but primary health care has to be seen in this broader context of what contributes to health and well-being. When we come to the services as such, the role of the community health worker is vital, the community midwife, the nurses, the local doctors. There's so much that can be dealt with at the primary level. And if you get primary health care right, you should stand to reduce burden on secondary and tertiary services, which in any case in low and low middle income countries may be hard to access anyway. So I think a focus on primary health care in the broadest sense is really important.
Thank you, Helen. I think that's going to come up in the context of some further discussion as well. But first, a question for Sundari. Some people want to know, and I know it's in your paper, where in the context of your review, where do you see the big evidence gaps that need to be filled? If you can sort of reel them off quickly.
Okay. Well, reading them off quickly is going to be the challenge. Let me start with saying that there's volumes written on universal health coverage, very few of them addressing sexual and reproductive health. There's volumes written on sexual and reproductive health and universal health coverage, but 99% of them are making the case of why it is important to have SRH coverage in UHC and not going into details. So to begin with, only 28 countries gave us some information on what is in the essential package of health services. About financing, very, very few countries have sexual and reproductive health sub-accounts that allows us to understand on a country-by-country basis how sexual and reproductive health services are financed. The financing literature, even the data I showed, is for a limited package of what they call costed ICPD package of services, which is not the comprehensive services. Most importantly, we know very little of what is happening on the ground in countries, who is sitting around the table, what is being put into those packages, what is being financed, and what is really the coverage that people have. So it's not a gap, it's a huge hole there. Thanks.
Thanks, Sundari. I'm sure there's more in your paper, but that's a good start, and I would certainly recommend everyone to read the review. Alan, people have heard so much about the role of civil society coalitions in demanding and effecting accountability in Kenya. In the light of your experience and Kalen's, can you speak to that question? Is that overdone? Is it something we are a rosy picture for us from the outside, or is that really how it is from a Nairobi view?
So indeed, there has been combined efforts by civil society across different sectors. Particularly our experience as Kellen has been that our first advisory note to government was not only by those working in the HIV, TB, or SRHR field, it also included people who worked in the media, people who worked on children's issues, people who worked on housing issues, people from the private sector. So there was an urgency and an effort by civil society to try and speak in one voice in terms of taking advocacy forward. And so even on matters concerning healthcare workers, it is a joint voice that people advocate and say we need better systems to hire, to protect, and ensure healthcare workers are able to access services. So there has been unity, but the problem has been sustaining that momentum, because the rate at which government sometimes is non-responsive, the rate at which the human rights violation keeps happening, sometimes is leading to burnout by civil society being able to keep up with all that. So that remains a challenge of how do you keep people going in a situation where sometimes the rule of law is not being respected and you're seeing more increased violations and you can't sort of cope up with what's going on around the country. But indeed, there has been greater collaboration among different civil societies and different movements in the country on seeing on the need to fight and stick together to get a better response to COVID that respects human rights. Thank you.
Can I ask you a follow-up question on that? Because we know how important this kind of mobilization by civil society is and has been to move the SRHR agenda forward, is Kenya an outlier, or how is it that this is becomes such an important element of the situation in Kenya?
I think to begin with, the presence of a legal framework, and before COVID, we had a very important we had two important judicial decisions. One that touched and taken forward by the Center for Reproductive Rights and FIDA around the issue of women being detained in hospitals for lack of payment of fees. And we recently had a decision around the court pronouncing itself to have guidelines relating to safe abortion to be reinstated. So there has been a lot of momentum within civil society in the health sector, and particularly those working on SRHR, on matters that deal with access to health services. And having UHC as a big four agenda in the country has led more engagement of civil society and communities to interrogate is actually the package that government is putting forward, working for the community. So this is just a follow-up, and COVID has then provided the opportunity for us to interrogate further that when you put certain measures in place like curfews enforced by the police and movement restricted at night or later on, how is this affecting the ability of women, young girls to be able to access services that are needed during times of emergency? So the push has largely been a momentum that has been built by the need to fight for the space and to ensure that the rule of law and the Constitution is respected. It's not an easy battle because there's always pushback and there's always the hiding behind let's do everything because it's a pandemic and pick up the pieces and bits of human rights and rule of law later on, but for now, save lives. Thank you.
Yeah. Thank you. Naomi, I found your data fascinating, particularly because the consistent message that seemed to emerge is that early and effective service provision actually reduces costs. And you showed that for safe abortion, that when the services are properly provided, yes, the cost of service provision goes up, but all of the other costs for post-abortion care and so on come down, so that the overall cost comes down. And it was the same thing for the other two interventions as well. But are you what if you're in a situation where the government doesn't want to provide abortion services at all and doesn't care? I mean, the costs are entirely borne by women, privately, illegally, on their bodies and out of their pockets, and the government doesn't care. Are you taking those kinds of how does one include those kinds of opportunity costs in terms of health into your costing framework? Because I think inevitably, if we are going to have to move the needle on policy in this, costing and budgets is going to be a very important part at the global and national ministries of finance are going to be interested in this.
Sure, thank you for your question. And I think that what you're laying out is unfortunately the situation in some countries. There are places where governments are not keen to invest in the services in the way that I laid out. But I think that we're here to talk about universal health coverage, and these same governments are making commitments to make care more widely available, to look at affordability, etc. And what we're trying to do with this analysis is to point out that some of the things that were highlighted in other presentations, in fact, that sexual and reproductive health involves a comprehensive set of services, that we should be investing in a comprehensive way rather than picking out the individual services that we choose, that these services are interlinked. And when we approach provision of care in that comprehensive, rights-based way, we not only save lives and improve health, but there are opportunities for cost savings that present themselves.
And are you taking all opportunity costs in terms of healthy populations, DALYs, and so on into account in your estimates?
The adding it up model looks at and in this analysis in particular, we look at the direct costs of service provision, and it's a normative approach. So this is what it would cost if we did it right. We don't look at who pays for care in this analysis, but again, as has been highlighted in other points by other presenters today, women do largely bear the brunt of the costs of accessing care. And that's another important advocacy point when we're talking about making universal access to sexual and reproductive health a reality as we work towards universal health coverage.
Thanks, Naomi. Manjula, the chat is going wild on self-care. So I'm going to throw two questions at you together and you can combine your answer. One is a concern about how would self-care work in marginalized communities? And the other is, are you really, is the whole move towards self-care letting the system off the hook? And if so, is it the right direction for us to be pushing? Sorry, you have 1.5 minutes for that answer.
Thanks so much. And yeah, I've been reading with a great deal of interest on the chat site. So I'll try and be brief. I think I think we need to be really clear about what we mean about self-care more broadly, and what we have guidance for is on self-care interventions, which are really tools or additional options that are quality interventions and that people can use. So I think there needs to be a little sort of distinction between those two aspects, and giving people choice and more options is always, I think, a good thing. Whether they can now access it because they're more vulnerable or they are marginalized or criminalized, I think that really it is the crux of the matter, and we do need to make sure that we're not adding further burden on individuals, but that we are really trying to provide a situation where they might have further choice. So that's one aspect. I think, for instance, in the context of COVID, you know, and in not so much COVID, but in the context of self-isolation, people, you know, need options that they can use at home and or when they're in isolation. And I think that self-care interventions provides additional opportunities in that context as well. But absolutely, you know, the concern is there, and I think we do need to tackle it. And one of you mentioned the SRHM special supplement on self-care interventions, and the supplement itself will be focused on the needs and the rights of vulnerable populations and how self-care interventions can support the needs of these populations. And it would be really interesting to see the kind of evidence base that we need to develop to support them so that we are not putting further burden on them. Over.
Thank you. And I think that's a good sort of qualifier and a cautionary note, because in this field, we've had too many situations where what looked good at the beginning ends up being exactly the opposite by the time we get to it. So it's very important that self-care not be used by those who would like to cut back on funding and services provided publicly through the public system. We just have a few minutes for some closing remarks. I think we've had a very exciting webinar and discussion. And let me first thank all of the panelists and speaking on behalf of the SRHM Journal, thank our partners, PMNCH, for a great collaboration. It's clear that this discussion could have gone on for at least twice the amount of time. And there are some issues I know which have shown up on the chat, but which we haven't been able to touch at all. Let me therefore thank all the panelists for your great contributions and encourage everyone to continue this discussion and also to read the articles as they come up in the journal. I have 3 or 4 points that I'd like to close us with, which I draw from this discussion. The first one that Helen made, which is that you cannot have universal health coverage unless it's predicated on health security. That is, handling the possibility of emergencies of this kind has to be built into, and universal health coverage equitably available to all is probably one of the strongest ways in which one can build in that kind of health security and capacity to handle. If we look in my own country, India, at the state that has done the best in terms of response to the pandemic, it's the state of Kerala. And in Kerala, of course, primary health care and the health system investment has been a long-standing story. And so, of course, with that in place, it's been possible to deal with the epidemic in a much better way. The second one is that SRH services, as part of UHC and provided through the primary care system, effectively provided through the primary care system, not only make it possible to reduce costs, but actually also fulfill women's needs and rights. And not only for women, but for all people, in fact. The third lesson that I drew from our discussion is that rights-based barriers continue everywhere. And as I said to Naomi, if we are to actually use this pandemic as a way to advance the agenda, the SRHR agenda, we have to be able to show that these barriers are in fact barriers to the realization of UHC and therefore to health security, but they're also highly costly. They're extremely expensive, not only in terms of the out-of-pocket expenditures that Sundari spoke about, but in terms of the overall health of the population, and the economic costs are very, very, very high as well. So we need to be able to say that and to show that, and I think I draw that lesson. The question of accountability and the role that women's groups and an enabling legal environment and political environment as well, I may add, cannot be minimized, and that came up as well. There are 2 issues that that we haven't talked sufficiently about and that I think are critical in this pandemic. One, the question of health workers and of the unpaid care work done by women, healthcare work done by women, both as a result of the pandemic, exacerbated, but also in normal times when universal healthcare isn't available. And it's for far too long that health workers, women health workers at the bottom of the health worker hierarchy, are expected to work as piece rate workers, as volunteers, not paid adequately and not paid on time. And if we don't change that, nothing that we do towards service packages for universal health coverage or for SRHR are going to work. And I think it's very, very important that in our advocacy, we pay attention to that. And the other is that the number of marginalized groups has grown dramatically, and particularly the challenges that informal sector workers, migrant workers, and others have faced during this pandemic point to the colossal needs that are there for them and on their behalf. It's very important that we as a community use this pandemic to move the needle, to take their rights into the center of our agenda. So with that, I want to thank you all very much. We have come to the end of our time. The chat is still going. Thank you all for being here. Thank you to the participants for a very lively chat session going on the side. Thank you all for being here, and I look forward to continuing these debates. Good night, good morning, good afternoon, and good evening, everyone. Thank you.